So continuing on with endocrinology, we already have a video on the first video on endocrinology in our playlist. So this is going to be the second video, and we're going to continue, keep on making integrations with different subjects. We're going to incorporate biochemistry, pathology, physiology, and also other systems as well. How endocrinology relates to other systems. So let's get on to it. So a 24-year-old woman presents for follow-up 12 weeks after giving birth. During pregnancy, she was diagnosed with gestational diabetes mellitus at 28 weeks of gestation and was treated with dietary modifications, exercise, briefly with insulin. She has maintained fairly good blood glucose control on diet alone, with fasting glucose readings consistently between 100 to 120. She has no personal medical history, but reports a family history of diabetes in her mother and gestational diabetes in her sister. Her vital signs are within normal limits. Her BMI is 22 kilograms per meter square, and her physical exam is unremarkable. A mild fasting hypoglycemia is suspected to be genetically predisposed. Right, so they have given us a scenario in this question. What basically they're asking is which of the following. So the following is going to be affected. So most importantly, they've given you a hyperglycemic picture. They've already told you that, but they've also told you that the hyperglycemia seems to be genetically connected. The pathology of the hyperglycemia seems to be genetically connected to the patient being predisposed to it somehow. So we know that genetically, the type of diabetes mellitus, the diabetes mellitus that is genetically associated mostly is diabetes mellitus type 1. Because this is an autoimmune disease, so this is mostly understood to be genetically associated with the patient. However, this is not a typical diabetes mellitus type 1 presentation. If you look at the presentation, we can see that the woman was diagnosed with gestational diabetes. And after giving birth, she has maintained a consistent reading. But 100 to 120 is still in pre-diabetic range. So the way you diagnose glucose or, diabetes mellitus is to have consistent readings of more than 126 milligrams per deciliter for fasting glucose. And any random blood sugar reading should be more than 200, or the HbA1c reading should be more than 6.5%. So this is the criteria of diagnosing diabetes mellitus. But this criteria is somewhat not falling for this patient. And this is a atypical kind of a presentation because this does not necessarily lean towards diabetes type 1 and is also not leaning towards diabetes type 2 because the BMI is also normal. And the readings, she's not getting the readings that are supposed to be classical for patients with diabetes type 2 or even for diabetes type 1. So we have reduced this is not diabetes type 1, as diabetes type 1 would present much earlier. It would not present in a person that is older than 24 years of age. And this is also not diabetes mellitus type 2, as diabetes mellitus type 2 would have a high BMI. So what is this? Now, this is a rare case which you might not see in reality in your life, but diabetes mellitus has more types. There are more certain kinds of types that are present that are more than type 1 and type 2. And one such type of diabetes is known as diabetes of the young, right, or mellitus diabetes mellitus of the young, and it basically occurs due to a certain genetic predisposition on certain receptors of the body or certain enzymes of the body, right? So, looking at this presentation, now we look at the answer. The answer is glucokinase. Now, what glucokinase basically functions is that it is a glucose sensor in the pancreatic beta cells. Now, if there is a mutation in the glucokinase gene, it raises the threshold for insulin secretion, resulting in a mild hyperglycemia, because now it will take much higher level of glucose to induce insulin secretion. So now if it takes higher level of glucose to induce insulin secretion, there would be an increased baseline glucose level in the patient's blood. And that is why the patient would have a fasting hyperglycemia, because that baseline level for that patient is normal, which for us, people that are normal, that are not genetically predisposed to that condition, in those people, it would be considered hyperglycemia. But for this patient, specifically, it is considered normal because the enzyme is particularly mutated. So it takes a higher level of glucose to activate the enzyme and to activate insulin secretion. The body does not consider this level that the patient has. This level is hyperglycemic because of the enzyme. So this type of diabetes is known as maturity onset diabetes, type 2. I was butchering the name a few minutes ago. It's known as maturity onset diabetes of the young, type 2. Now, most students, when they're seeing this kind of a question, they first they scratch their heads and they say that, do we have to remember the presentation? It's not as much as remembering the presentation or as much as remembering the diagnosis, rather than understanding what they're trying to ask you in the question. So this is a typical biochemistry question in which the presentation or the diagnosis that they're typically asking you is not something that you might have seen. It may be something that you are seeing for the first time. And this could be quite frustrating if you are sitting in the exam or if you're doing a self-assessment. Especially frustrating if you're sitting in the exam. But what the examiner is really trying to test is whether you understand the concept and the real question that it is trying to ask. So when you're reading this vignette, you could clearly see that this is not diabetes mellitus type 1. This is not type 2. And this is mostly talking about gestational diabetes. And the baseline fasting glucose readings are increased. So these kind of things that you could make out with, right? So you can understand it's not diabetes mellitus type 1, not type 2. It is something other than that, right? And also, for biochemistry questions, you must have an increased knowledge of other concepts as well. Because if you know what all of these enzymes do, you can easily cancel out and get to the right answer. So aldolase is not related to the glucose metabolism pathway, and enolase is not related to it as well. Let's open the explanation page so that you guys could actually learn the information. So aldolase is not related to the glucose regulation pathway. It is related to hemolytic anemia. It relates to due to the pyruvate deficiency kind of anemia. It's involved in that mechanism. You don't really need to know about that, but it is involved in that mechanism. Enolase is involved in glycolysis, but is not related to the insulin release or glucose sensing. So it's not related to the glucose regulation. Lactate dehydrogenase is again not related to glucose regulation, right? So this is not related to glucose regulation. Phosphofructokinase is again a glycolytic enzyme. It's not related to the hypoglycemia or glucose metabolism. pathway. So you can easily cancel out 4 enzymes based on knowledge of glycolysis. Pyruvate carboxylase is again another enzyme that is not related to the glucose metabolism. It's related to gluconeogenesis. So if pyruvate carboxylase is deficient, you would know that it would present as something that is related to gluconeogenesis, something such as lactic acidosis. And pyruvate kinase, again, it causes hemolytic anemia. This is a classical option, pyruvate kinase deficiency. It is not related to hyperglycemia. So this is again another way in which you can answer an obscure kind of a question. Right. So what I want you taking out from this question is that what glucokinase is. Right, glucokinase is a glucose sensor in the pancreatic beta cells, and its mutation leads to a disorder such as MODY2, majority onset diabetes of the young type 2. And I want you to know that what all of these enzymes do as well. All of these options that are given right here. Right, all of these options that are given right here. What these do, I want you to remember that as well. And how the presentation can get you halfway to the answer. So these things I want you to take away from this question. Moving on, I've actually showed a prevalence data in front of you that shows that how rare this disorder really is. You're not really going to find it in a clinical setting that much, but that makes it a good test question. It basically tests your knowledge of biochemistry. Right, so a bit of a difference that as type 1, it's not related to autoimmunity, and unlike type 2, it is not related to obesity or insulin resistance. And these other types that you really don't need to know now. We can discuss them in any future questions. So moving on, there's a 58-year-old man presenting with a painless neck mass, and it is enlarged. So he denies heat or cold intolerance, weight changes, or dysphagia. He has well-controlled hypertension and no history of radiation exposure or thyroid disease. On exam, he has a firm non-tender nodule in the right thyroid lobe. Serum TSH is normal, and thyroid ultrasound reveals 4 centimeters solid nodule in the right lobe. FNAC shows numerous follicular cells arranged in clusters and micro follicles. So what is the histologic appearance of the cells in this pathology? So first of all, we need to identify what kind of pathology they're talking about. You first need to understand the kind of pathology you're talking about, right? So the pathology at first we need to understand is that this is some kind of a thyroid cancer that they're talking about. First of all, that much is clear that there is a nodule in the thyroid and it is not hyper or hypothyroidism. So it must be a thyroid carcinoma. Now, the most common thyroid carcinoma, the fact that you need to know is follicular thyroid carcinoma, right? Follicular. And basically, they've actually given you the answer that the final aspiration actually shows follicular cells arranged in clusters and microfollicles. So then telling you that by this sentence, they're telling you that this diagnosis is follicular thyroid carcinoma. That's what they're telling you. So now they're asking what is the histologic appearance of the cell. First of all, you need to identify that the question is either asking for a particular type or any other type, and then you have to identify what is the high yield histological point related to it. And the high yield histological point related to follicular carcinoma is tumor capsular invasion. Looking at the answer, the follicular thyroid carcinoma cannot be definitely diagnosed by fine needle aspiration alone, as cytology cannot distinguish between follicular adenoma and carcinoma. The diagnosis requires histological evidence of capsular and or vascular invasion on surgical pathology. So something that you need to know that there is a follicular adenoma, there is a follicular carcinoma, and because both are generally originate from the follicular cells, what happens is that their pathology mostly is identical. But in follicular adenoma, if I could abbreviate it as FA, what happens is that in follicular adenoma, there is no, there is, let me switch this. There is no capsular invasion, right? In follicular adenoma, there is no capsular invasion. And in follicular carcinoma, there is capsular invasion. Now, why does this happen? There's a different whole story to it, but the way I remember it is that because follicular carcinoma is a dangerous cancer, it is a full-fledged carcinoma. So there are more cells, it is more dangerous, and therefore more cells, they invade the capsule. And follicular adenoma is a localized kind of a tumor. It is not dangerous. It is a few levels below follicular carcinoma, so it has less cells, and the cells are not able to invade the capsule. So that is how I have remembered the distinction between the two of them. And you have to remember that follicular carcinoma is the most common. All right. You need to remember that. It's the most common carcinoma. If they ask you what is the overall, let me rephrase that. The most common, the most common thyroid carcinoma. Let me first of all let me clean the place. All right. So this is an important point. It's a good thing I remembered. So the most common thyroid cancer is papillary carcinoma. It's papillary carcinoma. And the most common aggressive, dangerous cancer is follicular carcinoma. Right. So I hope this clears it up. I might have said that follicular is the most common. I meant that it is the most common aggressive cancer. The most common cancer generally, thyroid cancer, is papillary carcinoma. So you have to remember this line also, that it is showing follicular cells, because this is how you're going to identify it. They're talking about the follicular cancer. So I'm going to hold this slide for a second. You guys can see it has some high yield points regarding other options, and give them a read. All of this is important. Decorvin will have multinucleated giant cells. Hashimoto would have lymphocytic centers. It also has lymphocytic invasion. Ulcer cells can be found in thyroid neoplasms, but they're not diagnostic. And often any are characteristic of papillary thyroid carcinoma. This is an important point. You need to remember this. And of course, C-cell hyperplasia would be found in medullary thyroid cancer, because it is a new plastic proliferation of calcitonin producing cells, C cells. All right. That's what you need to remember. Moving on. So 55-year-old woman, and she has a newly diagnosed estrogen receptor, progesterone receptor positive breast cancer. She undergoes a breast sparing mastectomy, and margins are clear, and sentinel node biopsy is negative. She started on tamoxifen for adjuvant endocrine therapy. While on therapy, she develops hot flashes. So tamoxifen would increase the risk of which of the following? Right? That is what they're basically asking. Tamoxifen is a SARM. It is basically a estrogen receptor modulator, right? That's what this is. So what it does is basically acts as an antagonist on the breast and as an agonist on other organs, on basically your bone, your endometrium. And you know that if there is unopposed estrogen activity on your endometrium, there would be endometrial hyperplasia, because estrogen is the driver of hyperplasia in endometrium, in the uterine lining. That's estrogen is what builds up the endometrial lining. So if estrogen is unopposed and it is getting attached to the uterus and it is acting as an agonist on the uterus, then the endometrial lining would develop and the endometrial hyperplasia would result in subsequently being developed into cancer, because hyperplasia goes into dysplasia and dysplasia goes into uh, neoplasia, right? So, so there is hyperplasia, then there is dysplasia, and then there is neoplasia. So you need to remember this, that this endometrial hyperplasia would result in endometrial neoplasia and uterine carcinoma, endometrial adenocarcinoma very soon if this is not stopped. So this is what's going to happen. Now, there are other also estrogen receptor modulators like raloxifene, which do not act on the endometrial lining. So they do not cause endometrial hyperplasia or carcinoma. They are particularly preferred, but tamoxifen, as far as it is concerned, it can cause endometrial carcinoma. Right, so tamoxifen can work as an estrogen agonist in bone, so it will not cause a decrease in bone mass. Tamoxifen will increase the HDL levels, so it will not decrease HDL levels. And fibroadenomas are not related to tamoxifen use. And tamoxifen generally lowers the LDL, not increase. So you need to remember these points are also important. And also remember the part that tamoxifen is a part of SARM. There is also raloxifene, which is basically safer or more preferred. There is a 50-year-old man presents with a routine checkup, 20 years smoking history, consumes alcohol, occasionally eats red meat, fried food, sedentary lifestyle. The family history includes hypertension, bladder cancer, blood pressure is 160 by 90, and 70 pulse. Yeah, he is a diabetic. And what is the single most effective intervention for this patient? Right, so you can see that he has multiple problems going on for him. These kinds of questions, you need to have great knowledge of risk factors. You need to understand what the risk factors are. And because he doesn't specifically have any one condition, he's not diagnosed with any condition. So they're asking what is the biggest risk factor. And there is one golden rule that I'm going to tell you, is that as far as USMLE or NBME exams are considered, smoking cessation smoking is the biggest risk factor. Smoking is the biggest risk factor. So smoking cessation would be the biggest intervention that could definitely benefit this patient. You can say that he should modify diet, he should, control the glycemic index, glycemic levels. He should have his work done, his laboratory values done. But the biggest intervention that you could have is smoking cessation. Right? So this slide is filled with information. Go ahead, read it, pause the video. It's filled with information. You need to remember all of this. This would help you to actually answer questions that that are basically difficult in 11, but for you it will not be, because I have broken down the information very clearly. So fecal occult blood test is usually done in colon cancer screening. It's not indicated here. Prostate specific antigen test is not indicated. It's not even indicated in prostate testing. Daily aspirin is for primary prevention in cardiovascular disease. Dietary modification can help, but not as much as smoking. Regular exercise will help, but not as much as smoking. And tight glycemic control will help, but not as much as smoking. So this is important. You need to remember this. All right. So 21-year-old male athlete. He has fatigue, weight loss, despite food intake, and excessive thirst and frequent urination. There's decline in performance, and he is also sexually active. His father was diagnosed with colon cancer. Clinical picture is concerning for a metabolic condition. They're given you in the stem. So which of the following is the preferred diagnostic test? So polyuria, which means frequent urination, plus polydipsia, which means excessive thirst. You know that it is pointing towards diabetes mellitus, right? You know, it's pointing towards diabetes mellitus. And they also told you that there is a metabolic condition. So it's pointing towards diabetes mellitus. This was actually an easy vignette. That choices are high yield. You need to know about them. So the most preferred test for diagnosing diabetes mellitus is HbA1c. HbA1c, right? So this is the most preferred test to establish a diagnosis. Polyuria, polydipsia, and weight loss is classical. We change the. Let me change the color. Like the preferred test, and these are the classical symptoms. The options are high yield. Colonoscopy, again, it's not indicated in 21-year-old. It's indicated after 45. HIV testing is not indicated because there's no clues given in the stem that points towards risky sexual behavior. Serum TSH level, there are no symptoms that point towards a thyroid problem. TSH levels do not explain the polydipsia and polyuria, and urine analysis may not confirm the diagnosis because they might detect glucosuria in the urine. That glucose is present in the urine, but they might not confirm the diagnosis of diabetes mellitus. And this is not pathognomonic. Glucosuria is not pathognomonic for diabetes mellitus. It can happen in other conditions as well. You need to keep that in mind. And urine drug screen, it basically is absolutely wrong because we're not looking at any kind of toxicology. So these options were high yield. The vignette was quite easy, and basically giving you all the knowledge that you have to know to answer these kind of questions. So subscribe to our channel, and thank you for watching.